very good evening, one and all. I am Dr. Manjunath PR, Assistant Professor, working in Department of Endocrine, Ramaya Medical College Hospital and Hospital, Bangalore. So, as you all know, that Endocrine Society of India is conducting Facebook Live programs for few weeks, for the past few weeks, every Saturday, to increase the awareness of common endocrine problems, what is being encountered. As a part of this, today we are all here to discuss about thyroid disorders in children. As we know, thyroid disorders are one of the most commonest disorders encountered in our clinical practice. So it is very important for us to know what the thyroid disorders are, how they present, and what are the signs to be picked up in early presentation, and how to get treated, and what are the precautions to be taken when the patient are on thyroid medications. To discuss about these common disorders and practices, we have four eminent speakers for today's program. First, I would like to introduce Dr. Vijay Sarthi sir. So, sir is professor and head Department of Endocrinology, Vaidehi Institute of Medical Sciences and Research Center, Whitefield, Bangalore. So, he is the first Indian researcher on remission of type 2 diabetes, the contributor to ICMR and ISPE guidelines and type 1 diabetes, editor Cape News newsletter of ISPE 2014 to 18, and he has several awards like Best Resident Doctor KM Hospital Mumbai 2012, A.V. Gandhi Award for Best Research Methodology 2012, Young Investigator Award Vellore 2013, and Sir has several publications, more than 100 publications in national and international journals. And Sir's research interests are adrenal disorders, pituitary disorders, and pediatric endocrinology. Welcome you, sir.
Thank you, Manjunath.
Second speaker for the day is Dr. Ganivi YP. Madam is my colleague working as assistant professor, Department of Endocrine, Ramaya Medical College, Bangalore. Has attended numerous national level conferences and workshops, and received several grants from Endocrine Society of India, and has several publications in both national and international journals. So I welcome you, madam.
Thank you, sir. Thank you for
So the third speaker for the day is Dr. Krishna Reddy Thaduri, is a consultant endocrinologist presently affiliated to KIMS Hospital, Kondapur, Hyderabad, and has several achievements. So sir has achieved YC Mathur Gold Medal is an university topper, and has more than 10 publications in peer-reviewed national international journals, and his research interest is type 1 diabetes mellitus. I welcome you, sir.
Thank you.
So next speaker for today's program is Dr. Harsha Pamnani, currently working as assistant professor in endocrinology, People's Medical College and Research Center, Bhopal. Also works as consultant endocrinologist at Siddhanta Red Cross Hospital, Bhopal, and Trinity Multi Hospital. Madam has is a gold medalist in MD General Medicine, and has a Best Presentation Award in Epicon 2015, and has several various publications in reputed national and international journals. Madam's interest is in radioiodine ablation in hyperthyroid patients. So I welcome all the panelists for today's discussion. As I've already introduced, that today's topic for endocrine awareness is thyroid disorders in children. So with this introduction, I would like to start the question and answer session for today's program. So I would like to ask the first question for today's discussion to Dr. Vijay Sarthi sir. Sir, what are the common thyroid disorders in children, what you encounter in your day-to-day clinical practice?
A very good question, Manjunath. So indeed, the very common condition in children with respect to thyroid is actually goiter. Goiter is nothing but an enlargement of the thyroid, right? If you look at the causes of goiter in children, the most common cause of goiter in children indeed is a normal variation. Typically, there is a uniform enlargement of the thyroid gland around puberty, and that disappears in most cases after the completion of the puberty. But goiter could also be because of iodine deficiency, although the prevalence of iodine deficiency has rampantly come down, and because of which even iodine deficiency goiter prevalence has also significantly come down in the recent years. We still see some goiters which are presenting because of iodine deficiency. Here, the enlargement of the thyroid is more of a non-uniform, so what we call it as a multinodular goiter. The third common cause of goiter would be an immune damage to the thyroid gland, which may or may not be associated with any kind of an alteration in the thyroid gland function. The fourth, in fact, is though it's the last but not the least. So some goiters in children may be representing cancers in thyroid gland, which needs further evaluation. The second most common disease pertaining to thyroid in children is actually the hypothyroidism, where there is a reduced function of the thyroid glands with the reduced thyroid hormone levels. And this is typically because of either a congenital cause, that is the cause which has arisen at the time of birth, either because of abnormal development of the thyroid gland or because of abnormal or impaired production of the thyroid hormones from the thyroid gland. Whereas in the later stages, that is in childhood, typically this hypothyroidism results because of immune damage to the thyroid gland, or rarely even because of some surgical removal of the thyroid gland. For example, if the patient or a child has thyroid cancers, he may have to undergo thyroid surgery that may lead to reduced function of the thyroid gland. And the third, indeed, a relatively rarer disease is a hyperthyroidism, where there is an increased production of thyroid hormones from the thyroid gland. And again, most commonly, it is because of a autoimmune etiology, where our own immune system is fighting against our thyroid gland to stimulate the increased production of thyroid hormones. Over to you, Manju.
Thank you, sir. So the next question will be to Dr. Ganavi. Madam, is there any difference in the presentation in children compared to adults regarding the thyroid disorders? Can you please enumerate any differences in presentation between children and adults, madam?
Yes, sir. Thank you for the question, sir. So, thyroid disorders in infancy, each of it presents in a different way, and the symptoms are quite different than that of the adults. So, we know that the thyroid hormones are essential for the growth as well as the maturation of many targeted organs, including the brain and the skeletal system. So, as a result, abnormality of the thyroid gland functioning in infancy or childhood result not only in the metabolic changes which are in adults, but they present in a unique way in which bears an effect on the growth and maturation of these thyroid dependent infants and the childhood. So in most of the cases, the infancy and childhood, as we know, they are the critical windows for the development of the thyroid hormone dependent tissues, and hence the presentations is different in the different age groups. So, example, in a newborn child who presents with congenital hypothyroidism, that is the thyroid dysfunction which is present since birth, it presents in a different way. So, these infants usually have a post-grade, they may have a prolonged jaundice, may have a delayed form of a large anterior fontanelle which is being open and a posterior fontanelle which is open for beyond 6 to 8 weeks of life. They may also have breathing difficulties, they may have a large tongue, they may have a hoarse cry, they may also have hernia of the umbilicus, laxity of the joint with delayed passage of tools, dry post-sprint. They may also have associated deafness, heart defect, opening that is a split present in the lip as well as the upper lip of the mouth. So the birth length is usually normal in this stage, but adequately at the right age, they may have a stunted growth later on. Also, the features which I mentioned are very subtle and may increase as the time duration increases as well. So, since the thyroid hormones are required for the brain development, if congenital hypothyroidism is not addressed, they may also have delayed milestones as well. So, and if not treated for a long duration, they may have intellectual disability as well. So, this is the cause of intellectual disability, and hence it is recommended to treat. But in contrast, hypothyroidism that develops beyond 3 years of age, that is the time when most of the thyroid hormone dependent brain development would have already occurred, may present with short stature. That is the height gain may not be as compared to that of the peers. So sometimes the children just present with short stature and without any other features of hypothyroidism. So if a child is not growing appropriate to his or her age, a thyroid evaluation is a must in such a. So the other features are they're usually overweight compared to that their height. They may also present with an immature looking face. They may also have a goiter, that is swelling of the thyroid gland. They may present with late tooth eruptions. Sometimes they may present with enlargement. visual disturbances as well. Sometimes they may have drifting of the gait because of the slippage of the hip bone, and they may also present with delayed puberty and very rarely with precocious puberty as well. So in the sense of girls, they may have menarche without breastfeeding. Boys may have menarche within 9 months of age. So this usually happens with pubic hair development. So hypothyroidism basically is the presentation of the most serious form of infection is the short stature and staying puberty. So just like hypothyroidism presenting in neonates, hypothyroidism also can present in neonates, but usually they manifest after a few weeks to months. They usually present with premature closure of the continence, or they may present with unexplained increase in the heart rate, poor weight gain, poor feeding, diarrhea, and rarely they may present with prolonged jaundice as well as enlargement of the liver as well as the spleen. So sometimes they may also present with the rhythm disturbances of the heart, which may result in heart failure. So basically, in a neonate, unexplained increase in the heart rate, a goiter, also the staring look, all of this points towards hyperthyroidism. So hyperthyroidism can also present in children and adolescents. They may present with shortened attention span, emotional lability, nightmares, increased bedwetting. They may have increased frequency of urination, excessive thirst, diarrhea, weight loss with a decrease in the appetite, accelerated height growth, delayed puberty, and involvement of the eyes, basically a staring look, goiter, as well as headache. So these are the various presentation of children with hypo or hyperthyroidism. So hence these disorders are to be suspected if a child presents with the above manifestations. Over to you.
Thank you, madam. So the next question will be to Dr. Krishna Reddy. How do you evaluate for hypothyroidism in children?
Okay. Thank you, sir. Thank you, Manjana sir, for your nice introduction. Um, the identification of hypothyroidism in children is very tricky. Many times we'll be getting referrals from our pediatrics colleagues with a mild elevation of their TSH levels, and symptoms also very vague sometimes. Sometimes the children may be a little bit obesity. Their hypothyroidism may not be cause for this obesity, but there may be presentation could be something related to overweight and obesity, sometimes constipation, sometimes vague abdominal pain, and sometimes the lethargic child, the child is not having a good amount of the energy levels, even though their scholastic performances are good. So these are the children routinely screened by their pediatricians and referred to us for the hypothyroidism. Many times in children, we are catching them lately because of the later evidences from the short stature and sometimes pseudo precocity, and already the good amount of the time has been lost in diagnosing some of the children with the development of the frank mixed matters features. To know how to evaluate a child with thyroidism, we may need to discuss some of the basic points regarding how this thyroid is secreted from the thyroid gland. So we all know that the hypothalamic region in the brain, which will secrete the TRH, which acts on the pituitary gland. So this pituitary gland is a major endocrine organ which will secrete the TSH hormone. This is a thyroid stimulating hormone. So this will act on the thyroid gland to produce the major hormones of the thyroid function, that is T3 and T4. So to have a proper knowledge whether this how this thyroid gland is functioning normally or not, so we need to estimate that T3, T4, and sometimes free T4 levels and TSH. So this complete profile will give a full picture of the how the thyroid is functioning in the body. Sometimes, many of the times, almost 19, above 90% of the cases, estimating the TSH alone can identify the children with hypothyroidism. But rarely, sometimes, especially secondary hypothyroidism conditions. So there may be requirement for the need to assess the reflex T4 or free T4 level estimations. So this is basically required to diagnose the hypothyroidism in children. As the Sardi sir discussed, so majority of the cause for this hypothyroidism in children are iodine deficiency and autoimmune process. So to identify this as the individual level, the estimation of the urinary iodine doesn't give much identification in the diagnosis. But estimation of anti-TPO antibodies can give some thought inputs into the what is the cause for this hypothyroidism into the children. So this anti-TPO as prevalence is very huge, and not all the children with anti-TPO is positive. They may not progress into the hypothyroidism. So the estimation of anti-TPOs should be reserved for some of the children with goiter with the normal thyroid functions or any family histories there. Or any other abnormalities, anemias, and lipid abnormalities in the children. So these should be reserved for this kind of children. So along with this, if you any patient, especially secondary hypothyroidism, who has low amount of secretion of TSH, which will because decreased functioning of the thyroid gland, reflected by the low T3 and low T4. So these children may be need further evaluation with the MRI of the brain, and sometimes this autoimmune thyroiditis may be associated with some of the syndromes in the children's, like Turner syndromes and Down syndromes. So these syndromes also we should keep in mind and we should evaluate for them. And this is the autoimmune process. Autoimmune process is nothing but a बॉडी में कुछ एंटीबॉडीज प्रोड्यूस होके हमारा ऑर्गन्स के ऊपर उसका फंक्शनिंग कम करते हैं. So this is thyroid. Autoimmune thyroid is a thyroid problem. So which will cause the thyroid का functioning कम करने के लिए कम करते हैं. So along with this other autoimmune process also can be going in the body. Sometimes this is associated with the celiac disease, like something related to the problems with digestion, and something with related with sometimes this type 1 diabetes, vitiligo, and sometimes it may be associated with other autoimmune process. So we need to identify all these autoimmune process along with the hypothyroidism in children. If at all any associations, we need to identify them and treat them. As also we need to give some attention to the specific conditions in presentations, like pseudo precocious puberty is one of the prevalent conditions when the late onset hypothyroidism, long-standing hypothyroidism. So these children needs to be you should differentiate a true precocity or as a pseudo precocity. We need to differentiate because both have different treatment approaches. We need to go with them, as well as sometimes this hypothyroidism children also present with there's a problems in the leg, like slippered capital femur syndromes. So this also we need to identify them and evaluate them properly. Based on the evaluation, we can treat them. Thank you, sir.
Thank you, Krishna Reddy sir. So always we have to get a complete thyroid profile once when we diagnose hypothyroidism, because it's very important for us to rule out a primary or a secondary cause for hypothyroidism. So well said, sir. So now the next question will be for Dr. Harsha. What is congenital hypothyroidism and what are the causes? So in our day-to-day practice, we do get references from pediatrics, NICU and PICUs regarding the elevated TSH levels, and we are always have to take a decision whether to treat the neonate with the thyroxine or not. So to clear all our doubts, can you please take this question, Dr. Harsha?
Okay, so thank you, sir, for the introduction and good evening, all. So, congenital hypothyroidism, it is basically thyroid hormone deficiency which is present from the time of birth. It is most common treatable cause of intellectual disability, and if early and appropriate treatment is given, basically mental retardation or intellectual disability, it can be prevented. So, like its importance. Most important thing is that in the newborn, there are very few clinical features of thyroid hormone deficiency. So we should screen. We should screen. There should be active case finding in case of newborn to detect thyroid hormone deficiency. Now, coming to next questions regarding the types etiology. So first of all, there is like Reddy sir also told, like there is primary, secondary, and tertiary. These are the levels. Primary hypothyroid means defect is at the level of thyroid. Secondary means there is defect at the level of pituitary, which is master gland, which is present in the brain. Third means there is defect at the level of hypothalamus. When you come to etiology, in terms of primary hypothyroid, congenital primary hypothyroid, when defect is at the level of thyroid gland, there could be absent thyroid gland, which is agenesis, dysgenesis. There could be ectopic thyroid gland, means thyroid gland is not present in the normal location. There could be many genetic causes which could lead to thyroid gland deficiency. There could be problem with the thyroid hormone synthesis. There could be problem with the thyroid hormone secretion, or there is problem at the thyroid hormone transport level, or there could be problem at the metabolism or the receptors. So there are many genes involved which can cause primary congenital hypothyroidism. Second comes secondary or central congenital hypothyroidism, when defect lies at the level of pituitary gland. In some cases, when mother is being treated with hyperthyroid, ATD is being given in high dose, then a child may develop central hypothyroidism. And when there is birth trauma or asphyxia is there, there could be damage to the pituitary gland. In that case, there could be central hypothyroidism. There are sometimes there could be also transient causes, like in case of iodine deficiency, or if there is some blocking antibodies which transfer from mother to fetus, then it could remit by 3 months. There could be some or causes like hemangiomas that can cause transient. So regarding causes wise, there is primary congenital hypothyroidism, there is central congenital hypothyroidism. So thank you, sir.
Thank you, madam. It is very important for us to identify this state, that is a congenital hypothyroidism, because it is very important for the clinician to treat this condition. In the first 3 years, the neuronal development is happening. So it is very crucial for us to take a decision whether to treat the patient or not to treat the patient. So it is very crucial for us to identify this condition and to treat. And supposingly, if we are treating this condition, we have to continue the medications with the levothyroxine at least the age of 3 years, and then we can reassess at the age of 3 years whether they need to continue or not. So thank you, madam. So now we'll move on to next question to Dr. Vijay Sarthi, sir. Sir, what is neonatal screening and what is its importance? Because just now we have discussed about an important condition like congenital hypothyroidism. I think it is very apt for us to discuss about neonatal screening, and it is important. So over to you, sir.
Yeah, thank you, Manju. In fact, it's a very relevant question for today's discussion. As already highlighted by Harsha as well as Dr. Ganavi, that it's the congenital hypothyroidism, there's a thyroid deficiency which is not treated within 2 weeks from the birth. So that's going to reduce the intellectual ability of a child. So how do we identify these children? So as already even told by Harsha, that these neonates will not have much of clinical manifestations. So even an expert is examining a neonate with congenital hypothyroidism, especially before 1 month of life, 90% of the neonates with congenital hypothyroidism will be missed. Then how do we detect them? The only way left with is actually neonatal screening. So how do we screen? Though they don't have a clinical manifestations, they would be manifesting abnormalities in the blood in the form of an elevated TSH. As Reddy already told, this TSH is a signal that comes from the pituitary and makes the thyroid gland to work. So obviously, even in a milder thyroid dysfunction or a thyroid deficiency, though sometimes the thyroid hormone levels may be normal, but the TSH will be high. So we need to check for this TSH either in the cord blood, there's a blood from the umbilical cord, or once from a heel prick blood sample, maybe after 24 to 48 hours of life. So in the cord blood, the advantage is that so you won't be causing any pain to the infant, Also, there will be no blood loss to the infant because the blood will be squeezed from the placental side, that is the maternal side. And the third important thing is that since we are going to collect the cord blood, we are going to ensure that each and every newborn who is born in a hospital are collected or checked for a TSH level. In fact, it's very, very important not to miss even a single child because this is one of the disorder. In fact, I could say like each and every child on the earth has a right to have a normal intelligence, and they should not lose their intelligence because of the negligence of ours. So it's very important to screen each and every neonate for congenital hypothyroidism, which cannot be identified by the clinical examination. If at all, if cord blood is not collected, again there is a scope to do a sample on day 3 or later typically, though we can sometimes also do on day 2 of the life of a baby, especially if they're getting discharged early from the hospital. But typically here it is done from a heel prick. So when we do a TSH, if it's more than 40 points, we have to immediately start the neonate on treatment. Whereas if it's between 20 and 40 points, we may have to repeat the value on some other day and confirm that it is really elevated about 20 on a second sample and then start on the treatment. But the point here is that it's very, very important that each and every neonate or a baby born anywhere in the world should undergo TSH test before 3 to 5 days of life so that we don't miss any child with congenital hypothyroidism to come to us later on with a compromised intelligence. Thank you, ma'am.
Thank you, sir. The message is we have to repeat or we have to do a TSH before 5th day of life, or at least from 3rd or 5th day, we have to do a TSH to rule out this treatable cause, that is congenital hypothyroidism. This will be taken, sir. So the next question is to Dr. Ganvi. So how do you treat hypothyroidism?
So the treatment for hypothyroidism is recognized as well as treatment of hypothyroidism. That is different from the levothyroxine tablet. The goal of hypothyroidism is to thyroid function, both the C4 and the TSH as rapidly as possible, so that the side goes to a normal development as Dr. Saki sir has already mentioned. So the main treatment is the use of the oral tablet, that is levothyroxine, which should be started as soon as the diagnosis is correct. So in severe hypothyroidism, as the rightly said, there is no need of
Dr. Ganami, sorry to interrupt you. I think your voice is not clearly audible. So I would request Manju to take over answering this question, Manju.
Yes, ma'am. Can you please come closer and try, madam?
Sir, is it okay now?
Yeah, it's pretty good now. Please go ahead.
Is it okay now?
Yeah,
Yes,
it's absolutely good now. Please go ahead.
Yeah. So the treatment of both congenital hypothyroidism and juvenile hypothyroidism is the same. That is the use of the oral levothyroxine tablet. So the goal of treatment for congenital hypothyroidism is to normalize the thyroid function test, that is both the TSH and the free T4 as early as possible. So in case of congenital hypothyroidism, we start the treatment with the oral tablet, that is levothyroxine, as soon as the diagnosis is confirmed. Whereas if it is severe congenital hypothyroidism, the diagnosis, the confirmatory test is also not required. We start off with the treatment as early as possible. So it is important to start the treatment within the first 2 weeks of life. There is no need to delay the treatment for the imaging of the thyroid. So that is the message which I want to tell all the audience, that the treatment for congenital hypothyroidism should be started as early as possible, as Sir rightly said, because it is the most treatable, most common treatable cause of intellectual defect. So the dose in case of infants is quite high, especially in the first 3 months of life, which is then gradually tapered to a maintenance dose, and then it is usually continued up to 3 years of life. So it is very easy to administer the tablet. It is just given by crushing it and mixing it with either breast milk or with a formula feed or water, and it has to be done. Which has to be done prior to the administration. So it is important not to mix the tablet with the other preparations containing iron or soya or calcium, as well as they interfere with the absorption of the levothyroxine tablet. So also it is important to use the same brand for the treatment because the bioequivalence may be different with the different brands. Also, apart from this, the compliance of the medications is also very important. And if the therapy is started in the very early course of life, the outcomes of these children is quite excellent. So after we start the treatment, we monitor with the help of the thyroid function test. Initially, it is done fortnightly once till the thyroid functions normalize. After that, it is done every 1 month for up to 1 year of age, after which it is done once in every 2 to 3 months till about 3 years of age. So it is, as Dr. Manjunath said, it is it is very important for us to not to stop the treatment before 3 years of age, because the thyroid hormone dependent brain development would be occurring at this stage. So after 3 years, if at all, if the congenital hypothyroidism, if we suspect a transient cause or a temporary cause, or if the diagnosis is still not confirmed, then a trial of the therapy can be given for about 4 to 6 weeks. So again, if there is a rising trend of TSH, or if the TSH is more than 10 again, after 4 to 6 weeks of stopping the levothyroxine, the treatment is initiated again. But if the treatment is, but if the thyroid functions are normal, then it is important for us to monitor the thyroid functions till the child attains puberty or the normal height as well. So, coming to the treatment of hypothyroidism in case of childhood or in juvenile state, basically, it is the use of the with the use of the same tablet, that is the levothyroxine. So the dose in children is quite high compared to the adults. Why is this? One is because we calculate the dose based on the body surface area, as well as there is increased clearance of the thyroid hormones in children as compared to the adults. So again, the dose is basically based on the age as well as the body weight. Basically, again, the oral tablet is given, which is given just at least 1 hour prior to meals, half an hour to 1 hour, preferable prior to meals. So once initiated, and then we follow the patients for every 3 to 6 months till till the thyroid functions normalize, and once it is stabilized, probably monitoring again once in 3 to 6 months is recommended. So basically, the dose is again adjusted based on the body weight. So basically, what I want to tell is levothyroxine is a very safe tablet with minimal adverse effects, and hence the therapy should be continued, and it should not be stopped, or the dose should not be decreased unless it is advised by a medical practitioner. Because if the therapy is stopped or decreased, the hypothyroidism again ensues, and the presentations again, there may be faltering of height, there may be intellectual developmental delay, as well as a delayed puberty, which is quite serious. So hence, treatment with levothyroxine is the main modality of treatment for both congenital as well as juvenile hypothyroidism.
Thank you, madam. So the key is to start the appropriate treatment at appropriate age and time and frequent follow-up. So thank you, madam. So the next question will be to Dr. Krishna Reddy. So how do you evaluate hyperthyroidism in children? Till now we have discussed about the deficiency part. Now we'll move on to the excess states like hyperthyroidism. So how do you want to evaluate hyperthyroidism in children?
Yes, sir. Hyperthyroidism in children actually a very rare condition comparing with the hypothyroidism. Mainly, the symptoms are sometimes vague because bacho cannot. They will say they are having palpitations and they are having some difficulty, anxiety, something like. So the symptoms are very cannot be told by the children, and the diagnosis may be delayed, and the symptoms of ophthalmopathy, आंखों बाहर आना, आंखों थोड़ा बाहर दिखना, वैसा वो भी symptoms भी थोड़ा रेयर रहता है बच्चों में. इसलिए थोड़ा any child with weight loss or any history of any body shivering and passing excessive stools and any goiter and swelling in front of the neck. So these all children needs to be evaluated uh, with this thyroid hormone functioning test. So, as we discussed for the hypothyroidism, the similar test like T3 and T4 and TSH are required to assess the hormonal status in the body. Hyperthyroidism is nothing but overproduction of the hormones from the thyroid gland, or in thyrotoxicosis, there is release of the thyroid hormone from the thyroid gland. So both these pathways will lead to excessive T3 and T4 in the body, and with a reflex decrease in the TSH from the pituitary gland. So this is a classical picture, and sometimes this in the mild cases there may be TSH may be going down below zero point 0.1, and T4 may be normal, but T3 is little bit above the normal ranges. So these children needs to be carefully differentiated between thyroiditis. So this is thyroiditis, nothing but it's a transient phase of excessive release of hormones into the body. This later slowly that will progress into the normal thyroid levels, as well as they will slowly progress into the hypothyroidism. So these initial stages of thyroiditis and this Graves, the most common cause of hyperthyroidism in children, this is the Graves. So you need to differentiate between these two processes. So after confirmation from the laboratory T3, T4, TSH estimations, we may need to proceed with the technician scan of the thyroid gland. Sometimes, rarely, some thyroid nodules also can produce excessive thyroid hormone levels. So this is also can be detected in the technician scan as a functioning thyroid nodules. And in case of the Graves, there will be diffuse uptake of this technetium. In case of thyroiditis, that is, in thyroiditis, the uptake of the technetium into the thyroid gland is very, very minimal. So this is how we can differentiate. Sometimes this neonates, because of the maternal hyperthyroidism, because of the TSH receptor antibodies crossing through the placenta and going to the baby. Sometimes they may be present in the neonatal thyrotoxicosis phase. The vague symptoms like only diarrhea and failure to thrive, not gaining adequate weight. So very vague symptoms will be there. The clinching point is any mother with uncontrolled hyperthyroidism during their pregnancies. These children should be evaluated for any signs and symptoms of hyperthyroidism. If at all present, we need to evaluate accordingly. And very rarely, this hyperthyroidism could be due to some of the syndromes like McCune-Albright, and sometimes this thyroid tissue in ovaries and other part of the organs. So they need careful evaluation and careful testing for them to identify some of the rare cases of the hyperthyroidism in children. Over to you, sir.
थैंक यू डॉक्टर कृष्णा रेड्डी. वही है, अगर बच्चों में ना अगर ये हाइट का इश्यूज है या पेट का थोड़ा इश्यूज है और बच्चों में ज़्यादा इरिटेबिलिटी या हाइपर एक्टिव है और उनका वजन ज़्यादा नहीं हो रहा है, तो इनको हाइपरथायराइडिज्म रूल आउट करने का बहुत ज़रूरी है. तो अगर डॉक्टर ने हाइपरथायराइडिज्म डायग्नोज किया है तो उनका ट्रीटमेंट क्या होगा? सो टू आंसर दिस, so we'll move on to next panelist, Dr. Harsha. So how do you treat hyperthyroidism and what are the treatment options available?
Okay, thank you, sir. So, in children, most common cause of hyperthyroidism is Graves' disease. So, there are three treatment modalities which are available for the treatment of hyperthyroidism, that is Graves' disease in children. That is, one is antithyroid drug, second is radioactive iodine, and third is surgery. Actually, aspects of each and every treatment should be discussed with the patient, and patient preference should also be offered. So coming one by one, first is anti-thyroid drugs. Basically, we have methimazole, carbimazole, and usually propyl thiouracil is not recommended in children because of the risk of hepatotoxicity. So regarding the medical line of treatment, we have these anti-thyroid drugs, methimazole or carbimazole, and we have to give also symptomatic therapy. We have to give beta blockers like for raised palpitation or increased pulse rate. And for regarding the second means, there are also some side effects of these drugs. We have to explain the patients, like there could be sore throat, fever, rash, or vasculitis. There could be symptoms, alcoholic stools. We have to explain the patients that this could occur with this treatment. Second, there is the radioactive iodine, and radioactive iodine, it is contraindicated in less than 5 years of age. But if the patient, suppose the patient is being given antithyroid drugs for 2 years or more, even then the remission is not there, then we can offer the patient definitive treatment. In the definitive treatment, there comes the role of radioactive iodine and surgery. In that, we have to explain the need of radioactive iodine, but we have to be cautious. लाइक अगर पेशेंट की आंख बाहर की तरफ है, अगर ऑप्थेल्मोपैथी है, तो उससे ऑप्थेल्मोपैथी प्रोग्रेस हो सकती है, तो उन केसेस में नहीं करना है। बहुत कम एज है, 5 years से कम में कॉन्ट्राइंडिकेटेड है। बाकी रेडियो एक्टिव आयोडीन, इट इज लाइक इसमें परमानेंट हाइपोथायरॉइड का एक है, इसमें हो जाता है। थर्ड लाइन इज सर्जरी. सर्जरी यूजुअली इफ द ग्लैंड इज वेरी लार्ज, इफ देयर इज मीन्स अगर थायराइड का साइज बहुत बड़ा है और वो ऑब्स्ट्रक्टिव सिम्टम्स आ रहे हैं उससे, खाने में, बोलने में, सांस लेने में, किसी में तकलीफ है, तो बेसिकली सर्जरी का रोल है। एंड सर्जरी mainly for large gland, and in those cases in which remission is not there. Second, the sir has also discussed regarding the McCune Albright. If the McCune Albright is the cause of hyperthyroidism, then in those cases usually definitive treatment like radioactive iodine or surgery has to be given. So actually patient profile has to be seen, and each and every aspect of the patient, each and every aspect of the treatment should be discussed with the patient before giving the treatment. If the hyperthyroidism is mild and there is very small goiter, then we have to start with anti-thyroid drug. But as anti-thyroid drug remission rate in children is very less, only 20 to 30% if you give it for 1 or 2 years. Then we have to see radioactive iodine. Then there are some pros and cons of this therapy. Then we can go for surgery. And for the symptomatic treatment, we have to go for like beta blockers. And if the patient is in thyroid storm, then there is also glucocorticoids and other treatment which we use for thyroid storm also. And suppose some patient is intolerant to antithyroid drugs, then there is cholestyramine or lithium, then other modalities are there.
Thank you, Dr. Harsha. Patient profile and age are the key parameters here to decide upon the treatment. So we'll move on to next question. So हम जब भी हम पेशेंट को ट्रीटमेंट के बारे में बताते हैं, पहले पेरेंट्स हमको पूछते हैं कि दवाई पूरा जिंदगी खाना है नहीं खाना है, कब छोड़ना है, कब लेना है, कैसे लेना है। हमेशा हमारे several questions are always asked. So to solve this question or to highlight about this, so to Dr. Vijay Sarthi sir, does the thyroid disorders require lifelong therapy or not?
Yeah, Manju, I think like I absolutely agree with you. This is a question of like most of our thyroid patients, so whether they're children or adults. But most of the time we say yes. But there are also some exceptions I would like to bring. For example, if we have someone who had hypothyroidism from birth, that is congenital hypothyroidism, sometimes it could be temporary. So like for example, especially somebody who had an initial TSH of less than 50 points, and despite being on treatment, they never elevated their TSH above the normal range. Very likely that they may have temporary hypothyroidism. Obviously, we don't want to stop them because we don't want to take a risk. Still, the brain is in a growing phase, especially where it is dependent on the thyroxine for its good function. But at the end of 3 years, when these kind of children could be stopped off thyroxine and see whether they really require thyroxine or not. If the TSH is maintained less than 10 points, as Dr. Ganavi has already mentioned, so probably we need not have to consider the medication for them. But if it's more than 10, again, we need to restart and continue for the rest of their life. But somebody who had a severe hypothyroidism from birth, for example, somebody who had an initial TSH of more than 50 points, or somebody on any treatment during the first 3 years had elevation of TSH at some points or several points, requiring a further increase in the dose. They are the ones who would anyhow would require lifelong replacement therapy. But when it comes to the later acquired forms of hypothyroidism, most of them will require a lifelong replacement therapy. But let me tell a point here. Many a times they have been wrongly started on treatment. For example, a child with obesity goes with a TSH of like 6 or 7. They may be started on treatment, though they may not get any benefit from thyroxine. So those kind of children, there is a good scope that we would be able to stop thyroxine therapy. Indeed, quite often, if they lose weight, that may automatically normalize the TSH levels in those children. But those who had an immune damage mediated hypothyroidism, they would definitely require a lifelong therapy. On the other hand, if we talk about hyperthyroidism, where there's an increased production of thyroid hormones, as Dr. Harsha rightly pointed out, though we could push these children into remission, where they can go out of the antithyroid drugs after few years of therapy, that happens only in around 1/4 of patients. Whereas the remaining 75% of the patients will require some form of definitive therapy, which may be radioiodine therapy or a surgery, depending on the patient profile. So the first 1/4 of the patients who respond very well, so they would be able, we can take them off any kind of medications for rest of their life. Whereas those whom we treat with radioiodine therapy or a surgery, since they're going to develop hypothyroidism in the future, when the hypothyroidism develops, again they need to be treated with thyroxine, probably for rest of their life. So this is how we have to explain the parents of the children who asked about the need for lifelong therapy for thyroid disorders in children. Thank you.
Thank you, sir. Though the answer is very clear that they might require thyroid therapy for quite a long time, there are certain subset of patients who might require this therapy for a transient period of time. So to know where they fall, they have to keep continuous follow-up with their clinicians. So with that, we'll move on to the next question. So usually we have seen few parents getting their children with some neck swelling. So our job is to identify whether it is a thyroid nodule or not, and if it is thyroid nodule, how to evaluate. So to know about this, we'll ask this question to Dr. Ganvi about how to evaluate a thyroid nodule in children.
So thank you, Dr. Manjunath, for the question. We know that the thyroid nodules in children is quite rare, especially in the first 2 decades of life, it is quite rare. But if it is present, then it can be slightly associated with a higher incidence of malignancy as compared to the adults. So a nodule which is suspicious of malignancy can have the following characteristics: that it can be painless, it can be firm or hard in consistency, it can be fixed to the surrounding tissue, or there may be family history of thyroid cancer, or the child would have received any radiation of the neck as well as the thyroid radiation as well. So the other worrisome findings for which is suspicious, which could point towards malignancies, are if there is a history of a rapid increase in the size of the nodules, or if there is an involvement of the lymph nodes which are present associated with an enlargement of the associated cervical lymph nodes, or if the child presents with hoarseness or dysphagia with a thyroid nodule. So all these features are suspicious of malignancy and hence has to be addressed as early as possible. So whenever a child presents to us with any thyroid swelling, we usually order a few blood investigations along with the ultrasound of the thyroid. So the blood investigations which are usually ordered are to assess the functionality of the thyroid gland. So they include the TSH, the T4 as well as the T3, as well as the anti-TPO is also done sometimes. With the anti-TPO, that is the thyroid antibodies are positive, then it indicates that it can be an underlying autoimmune condition with inflammation of the thyroid gland. But if the TSH is low with the T4 and T3 being high, then it indicates that the nodule is functional, and further it can be confirmed by special scans called the radionucleotide scans. But if the TSH is is high with the T4, T3 being low, then the hypothyroidism is confirmed and the patient is started on levothyroxine treatment. Along with this, along with the blood investigations, the ultrasound also is ordered in these patients. So basically, why is ultrasound ordered? In order to know the characteristics of the nodule, whether it is solid or cystic. Cystic means that it is filled with the liquefacious material, or whether it is single or multifocal, also will help us decide regarding the management. So if the nodule size is more than 0.5 or 1 centimeter in a child and the characters on ultrasound are suspicious of malignancy, then we usually order for another test called the FNAC. That is the needle test. So basically, FNAC, if it is normal, then we usually ask the patients to repeat the thyroid functions with the ultrasound of the thyroid after 6 months. Again, if at all, if it is suspicious of the malignancy or if there is a significant increase in the size after 6 months, we again go for the FNAC. But if the FNAC is suggestive of malignancy, then the surgery is the modality of treatment here. But if again the FNEC is inconclusive, so in that particular scenario, molecular testing is done, which can help us decide the modality. So in a nutshell, thyroid nodules in children is rare, but if present, requires evaluation by the blood test, blood investigations, as well as the ultrasound of the thyroid.
Thank you, madam. Thank you, madam. So, as we know, thyroid disorders are very common. We have few more common questions what we encounter in daily practice. लोग आएंगे पूछेंगे डॉक्टर साहब थायराइड अगर बच्चों को थायराइड है हम गोभी खिला सकते हैं नहीं अगर सोया खिला सकते हैं नहीं सो बहुत सारे क्वेश्चंस आते रहते हैं तो ये क्वेश्चंस आंसर करने के लिए डॉक्टर कृष्णा रेड्डी हाउ डू डाइट अफेक्ट थायराइड डिसऑर्डर्स
It's a very common question, sir. Many times people will ask whether diet is causing the thyroid problem, whether without not having enough iodine in the diet having this thyroid issues, और कैसा खाना डाइट के साथ कितना गैप देना टैबलेट खाने के बाद कितना गैप देना so ये very 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 common questions and very some of the times the practices is also very bad. I will deal with this subject. So what are the effects of diet on the thyroid function? And second thing, how we should time the diet in accordance with the tablet ingestion. So regarding the diet, some of the micronutrients are very essential for the thyroid function. For example, iodine is almost good amount of iodine is present in the thyroid gland. And to have a proper formation of the hormone, we require sufficient amount of the iodine. So whenever there is a dietary deficiencies of iodine is there, and the patient is consuming non-iodide salt, so there is a risk for that patient to undergoing for the patient to having hypothyroidism. Many times we are seeing some non-iodized salt has been propagated like a low sodium diet, so low sodium salts good for the health, but that is not true. And we should all encourage that iodine should be there in our regular diets, especially many of the reproductive women and pregnant women, so they are consuming that natural salts without proper iodification, so that can have a detrimental effects on the mother as well as the baby's growth. Along with this iodine, some of the other micronutrients like selenium and other waters is also very important for a proper functioning of the thyroid gland. And coming to the foods that will cause the thyroid dysfunction, the family of this Brassicaceae family, like cabbage, pulka gobi, patarka gobi, and broccoli, and these family they will produce some amount of their some things, so that will cause this iodine entering into the thyroid gland that will make difficult by this plant products. So this will cause sometimes hypothyroidism. The problem here is many a times we take them very not regular basis. We take very occasionally, and that too after a proper cooking. And if you remove the water from after cooking from these type of foods, the toxins can be removed from these things. They can safely consumed. Uh, these things occasionally, after properly cooked and removing the water, they can safely taken and without any major issues. And in the normal population, without any hypothyroidism or autoimmunity, So these foods doesn't cause even with a higher amount of consumption also, only mild reduction in the thyroid function has been observed. So other thing is the soy products like tofu and soya milk and other soy related products. So this is also cause dysfunction and in the production of the thyroid hormone in the body. So these foods also will you need to reduce and cut down in the when especially when you are having hypothyroidism problems. And regarding some of the things like some gluten products and some of the things, they can initiate the autoimmune thyroiditis problems, but we cannot completely rule out these products from who are, doesn't have any hypothyroidism. Coming to the second part of the question, how much gap should be there for the food intake and the thyroid hormone tablet intake? So the study is showing that at least you need to have a 6 hours of the fasting, then followed by the you should take your medication with the water. So water is allowed. There is no need to stop the water intake, and at least you need to wait for 1 hour of any food intake. And sometimes the patients will be getting confused that breakfast means they will think only of the solids. They will take the coffee and other milk products and they will take the medication thinking that it's not a breakfast. But the problem with this milk products and tea and coffee, so they contain a lot of anti-absorption elements. So they can also reduce your thyroid medication absorption into the body. So at least you need to maintain a gap of 1.5 to 2 hours for these milk and tea related products. And vitamin C and lemon, they can safely take lemon water, so they can sometimes increase the absorption. But solids, they should make a gap of 1 hour. And for other products and milk products, you should give at least gap of 2 hours before after taking the tablet. Over to you, sir.
Thank you. So I understand with children it is very difficult to maintain the timing and also to avoid the food intake what they really like. So it's a difficult task for the parents to make sure all these precautions are taken and the medications are delivered appropriately. So the next question and the final question is to Dr. Harsha. So what are the precautions to be taken by the patients while taking thyroid medications?
So thank you, sir. Many of the things of these questions have been taken by the panelists, Vijay sir, Dr. Gyanvi, and Reddy sir. But just to answer this, actually the thyroid medication which is to be given is levothyroxine, that is LT4. It is the preparation which is used for the treatment of hypothyroidism. And the medication, it should be ideally given in the empty stomach and at least 6 hours of gap from the last meal, and iron, calcium, or other vitamins or PPIs, anti-acidity drugs, which are to be given at a gap of at least 4 hours. And means patient has to take it in the empty stomach, but in the newborn and in the children, it's very difficult. But in newborn, it can be crushed with the and it can be given in the breast milk. But we have discussed that soy preparations and iron calcium preparations, they are to be avoided, and it can be given in newborn with the breast milk because it is difficult in newborn to follow these types of precautions. And the thing is that the medicine is heat labile, so means it has to be maintained in the room temperature, and heat destroys the medicine. So do not keep the medicine in too much hot area. And excess of medicines can cause headache, or if the patient can take in high dose, then it can cause acute psychosis, or it can cause headache, or pseudotumor cerebri. It can be caused if the levothyroxine is given in excessive dose. Rarely these side effects can be seen with the levothyroxine. And regarding the side effects of the anti-thyroid drugs like PTU, it is prone to cause propylthiouracil, it is prone to cause hepatotoxicity, and other side effects like fever, rash, vasculitis, and alcoholic stools, other could be caused by anti-thyroid drugs. So these are the precautions, and we have to tell patients the precautions which has to be taken, like side effects. We have to explain the patients in detail with the medication.
Thank you, Dr. Harsha. So now we'll see if there are any questions in the chat box. Oh, there are many questions in the chat box. Few we have already answered. That is, what are the common type of thyroid disease in pediatric age group? We have answered this question. So, is congenital autoimmune hypothyroidism, and what type of thyroid cancer in pediatric group is common? Somebody want to take up this question? So, what is the common type of thyroid cancer in pediatric group?
Manju, the papillary thyroid cancer is the most common cancer in children, like adults as well. But the point we need to note two different points when compared to adults is if you have a nodule, that as Dr. Ganavi already mentioned, there is a discrete focus of thyroid tissue which is separate from the rest of the thyroid gland. So such nodules are much more likely to be cancerous in children compared to an adult who has a thyroid nodule. And the other part of cancers in children is the papillary thyroid cancers are usually, though they are more likely in a given nodule, they are less aggressive. They're not as serious or advanced as seen in adults. Right.
Yes, sir. Next question is, does any new therapies to reverse congenital hypothyroidism? As far as I know, I don't know any therapies to reverse congenital hypothyroidism. So any
The
panelist would
point
like to
probably
take
we
it?
have to tell the audience here is that, see, like the thyroid hormone is a very safe medication, right? So it's so simple that you have to just spend 10 seconds of your life on the taking the tablet. So in fact, the cost of tablet is also not very high. So except that probably we may have to monitor the TSH levels now and then. That's the only additional burden which is going to come in their life, other than spending 10 seconds every day to take a safe medication. So obviously, there's no need to look for an alternative therapy. So there's no need to look for hypothyroidism to reverse. Indeed, that's the reason why scientists are also not interested to work on that, right? So it's better to accept the disease, okay, continue with the thyroxine therapy, right?
Very well taken up, sir. Unlike the other anti-thyroid drugs, which can have multiple adverse effects and which are very dangerous, thyronome has like less side effects, or like it is usually very safe to be taken by any age group. I think well said, sir. So rest all other questions, I think more or less we have answered. So whichever are remaining can be answered through Facebook later on. Now, I would like to conclude the session and request the panelists to give a single line message for our audience as a take home message from the today's talk. I would like to request Dr. Sarthi, sir.
Right, Manju, let me start this. Indeed, like I will start with day one of life of any person. So I would like to reiterate that every child on the earth, especially in India, where we are failing to establish newborn screening programs, we should ensure it's a responsibility of both the doctors as well as the political people as well as the parents, that we have to ensure that each and every newborn born in India should undergo evaluation for thyroid disorders at birth, that is congenital hypothyroidism at birth.
Dr. Ganvi.
Yes, sir. So thyroid disorders are quite common in children. It is important to recognize them, and the most common cause of intellectual disability being the hypothyroidism needs to be addressed in children. And the only modality of treatment as of now available is levothyroxine, and hence alternative regime is better to be avoided, especially in the pediatric age, for the treatment of hypothyroidism.
Dr. Krishna Reddy.
Yes, sir. I will urge everyone to take iodized salt, not to go for the non-iodized salt, because majority of the states in India are iodine deficient. And second more thing, never stop your medication and test after 1 month. Don't test that. So take a proper testing while on medication. And if any dose adjustment need, consult your proper endocrinologist and then proceed.
Dr. Harsha?
Yeah, congenital hypothyroidism is the most common treatable cause of intellectual disability. So, screen each and every child from day 3 to day 5 and make sure that if there is hypothyroidism, do take medicine. It is quite cheap and it is very less rare, no side effects that can be taken, and do not stop your medicine. Follow proper precautions and do proper regularly your thyroid function test.
Yeah. So screening is very important. Never miss a congenital hypothyroid patient. Always identify the signs and symptoms of a juvenile hypothyroid and treat them and get treated. And always don't forget to take the medications in an appropriately prescribed way. And always have a frequent follow so that you never know, you may fall into that transient kind of thyroid disorders where the medications can be stopped also. So you have to have a frequent follow. So I thank every one of you. Now I would like to request the team to put the flyer. So because we are all aware that it's going to be a January 2023, every January we are going to celebrate or observe as a Thyroid Awareness Month. So as a joint venture, Endocrine Society of India and Thyroid Indian Thyroid Society are jointly organizing an interactive Facebook live session 7 p.m. to 8 p.m. on January 3rd, that is Tuesday. So we request all the audience to be a part of this initiative and to spread the awareness of thyroid disorders among the public. So we request you to join. So this is again it's the entire month, like from January 3rd to 31st January 2023. We will have an interactive session in the Facebook live. So thank you, Endocrine Society of India, for giving a wonderful opportunity for all of us, and thank you all the panelists for taking your time off and giving your valuable suggestion and having an interactive session here. Thank you, one and all.
Thank you,
Thank you,
everyone.
Manju, and thank you, ESI.